Hi there, welcome back to this next masterclass on the thromboembolic disease. My name is Russell O'Brien, consultant in acute medicine at the Royal Devon and Exeter Hospital. Um, just a bit of a recap if you're coming straight to this masterclass and not seeing the others. In the previous two masterclasses, we've looked at the two other elements of Virchow's triad, namely stasis and endothelial injury. And in this, we'll look at some slightly more advanced cases again regarding hypercoagulability. I've made the point in a couple of the other masterclasses that I'm trying intentionally to focus on things that aren't the most basic level, perhaps for years 1 and 2 students. So some of these are cases that will build on things that you will have learnt in the early years, but are perhaps more advanced. So if this is all relatively difficult for you to take in, then please look at some of the earlier masterclasses and also some of the year 1 and 2 content. So I'm going to start with this very sad case who I saw when I was a registrar. And I don't remember her name now, but I'm going to call her Georgia. But I always remember seeing her actually on a dialysis unit. And she was normally fit and well and had come home on the bus from work and had been feeling absolutely fine. Then halfway home just started to feel, a little bit grotty, a bit of a headache, a bit fevery. And by the time she got off of the bus at home, she was really starting to have rigors. She got home, and very quickly after getting home, she started noticing that she had a purpuric rash starting to appear on her limbs. She started to feel so unwell that she just rang an ambulance, quite rightly, and came into hospital. I'd seen her a couple of days down the line, but by the time she arrived in hospital, necrotic areas were starting to appear on all 4 limbs, and a typical blood test for her might look like, as you can see here, her hemoglobin's down a little bit, her white cells are through the roof, her platelets are very low for a woman of her age. Her INR, she's not on any anticoagulant, so this is her prothrombin time. It was 3 times normal. Similarly, her APTR was 5 times normal, and fibrinogen, as we talked about in the first masterclass, was very low. It was being used up, and a D-dimer was 2,987. So, clearly she's very, very unwell. And what's the sort of differential diagnosis here? Well, before we get to actually what might be causing this, it's important to think about what that kind of picture seems to suggest. And it does suggest something called disseminated intravascular coagulation, or DIC. And this is a consumption coagulopathy, and that's why things like her platelets are low and the red cells are dropping. Also, there's a lot of D-dimer out there. She's clotting all the way. And it's a slightly paradoxical situation because you have both bleeding and thrombosis. There's an acute and a chronic form. So she clearly seems to be suffering from an acute form of disseminated intravascular coagulation. And so what do we think of the causes here? Well, the story for her is very much one of a febrile illness, and her white cell count was 30. So clearly sepsis is a big thing for her. And here's a quick list of some of the causes of DIC. Sepsis is a very common one acutely, and in fact this woman turned out to have a meningococcal septicemia. But you can get it from malaria, major trauma where you've lost a lot of blood, it can happen, transfusion incompatibility, and you do see it both in malignancies and also in eclampsia and pregnancy. I mentioned that there's also a chronic form that's not usually quite so dramatic as what we're talking about here with Georgia, but you do see a chronic form that occurs often in certain malignancies, for instance, mucinous carcinomas of the pancreas. And this is a sort of summary slide, really, of what's going on. You'll recall that a cardinal feature of DIC is that you have bleeding and thrombosis because you're just using everything up. So you've got tissue factor, which is obviously activating the coagulation cascade, as we talked about in the first masterclass, and direct damage through toxins and infection or whatever stimulates platelet activation, and this triggers DIC. On the one hand, you've got thrombosis, which will occlude blood vessels, even in the microvasculature, so you start to get tissue ischemia and damage, and you can get what's called a microangiopathic hemolytic anemia as well. And on the other side, because we're making so much clot, we end up consuming all of our clotting factors. We end up activating things like plasmin, and fibrinolytics start to come into play. And so as a combination of all of those factors, the patients are also at significant risk of bleeding as well. So it's totally a double-edged sword. So that's DIC, and that's a hypercoagulable state on the back of all of those potential causes here. Something slightly different now, and we'll pick this case up a little bit in the investigations masterclass, which I'll come to shortly. So this is actually a case in reverse, and when I was at medical school and where I was working in immediately after medical school, there was a very well-respected professor, and he died after a relatively short fight against cancer. But he had been ill briefly 4 years before, but with a long interval where he'd been fine. And this is what he had. About 4 years before, he was a very fit guy, did lots of running, and out of the blue, he had a deep vein thrombosis, quite a big one, and got treated. So this is an ultrasound just showing occlusion of the common femoral vein. So the link here potentially is his later cancer. And it is recognised that people who have malignancy have a very marked pro-thrombotic state for a whole variety of reasons that I'll come back to. This is quite well documented, or the whole of the sort of history of cancer is well documented in a book called The Emperor of All Maladies. And cancer has so many ramifications that it's not surprising that an increase in thromboembolism is one of them. Essentially, cancer affects all three of Virchow's triad in one way or another, and not necessarily in all patients, but certainly it can do. So it can increase hypercoagulability, it can predispose to stasis, and I think we covered that earlier by obstructing vessels, things like superior vena cava obstruction or pelvic masses obstructing the leg veins. And there is a degree of endothelial damage, either through cancers themselves, but also the treatments as well. So I'm just going to move on to a couple of slides that just summarize this. This is relatively advanced stuff, and the detail is more for illustration. So again, this is pitched at more senior students and those with perhaps particularly interested in oncology. But what can be associated with cancer are pro-thrombotic states, and some of these just present as things like DVTs or pulmonary embolisms, often months or even years before the patient is actually diagnosed with their cancer. So idiopathic venous thromboembolism is probably the most common, but you can see there's a whole range of thrombotic syndromes that have been associated with malignancies, including an aseptic form of endocarditis and of a DIC, which I mentioned before. So these are relatively small print, but I think just understanding that sometimes unprovoked venous thromboembolism might be a harbinger that somebody has underlying neoplastic disease is important to know. We'll revisit that in the next masterclass. The reasons why people will have venous thromboembolisms when they are suffering from cancer or being treated for cancer are really legion, and these are just summarized here, and they can be anything from natural increases in things like tissue factor, a more pro-thrombotic endothelium, oncogenes relating to the cancer that produce a pro-thrombotic state, right through to things that relate to what we're doing to the patient. So we're putting indwelling catheters for chemotherapy. They're often going to be immobile. They may have had operations. The tumour itself might be obstructing. And there are a number of pro-thrombotic drugs as well, which I'm going to summarise in the next slide. So there's a number of drugs that can affect clotting in various ways. The first things to just talk about some of the common ones. So tamoxifen is a very common anti-estrogen used in breast cancer predominantly, and this can reduce antithrombin and protein C, those antithrombotic factors. So there is an increased risk of venous thromboembolism when you're on that, and a whole range of other therapies. So things like cisplatin can increase von Willebrand's factor, and things like EPO and some of the treatments in the acute leukemias can all produce a pro-thrombotic state. Other drugs will damage the endothelium directly, and it's perhaps not surprising, and maybe all chemotherapy agents will do this to one degree or another. But in particular, the drug cisplatin which is a very common chemotherapy agent, and thalidomide, which is used in myeloma and a number of predominantly hematological conditions, can all damage the endothelium as well. Finally, and pretty small print, but it's perhaps not surprising that some of the drugs that work directly on blood vessels also can be associated with changes to the endothelium that predispose to clot formation. So that's a sort of summary of some fairly advanced level topics around hypercoagulability. It's also, these things are, hypercoagulability can be down to much more straightforward things like sepsis. It can be down to more straightforward things like smoking. But hopefully that gives you an illustration of two or three very important areas, namely DIC and the association of cancer with a pro-thrombotic risk. In the next talk, we're actually going to shift away from Virchow's Triad and look at investigating venous thromboembolism. So this is a much more clinically focused lecture, looking at a number of cases and some of the nuances and the practicalities of how you go about investigating venous thromboembolism. Thanks a lot.